Bach, Toccata and Fugue in D minor, an iconic melody accompanied by, perhaps, thunder, lightning, the ominous silhouette of an elm tree, a creaking door, the gates of an asylum. And within this asylum, a man thrashes about with a straitjacket, locked in a room unsupervised. Other men and women linger in the hallways as might a phantom roam the churchyard. The nurses and doctors struggle to tame the unruly, unhuman crowd. So is the image of psychiatric institutions, a sort of house of horrors, and back in the beginning of the 20th century, these facilities weren't the most pleasant of places. These hospitals, however, aren't exactly a common sight anymore, their absence sorely noted not only in the massive abandoned structures they left behind, but also in the quality of mental health care today. You see, though certain institutions were indeed frightening places, these institutions began shutting their doors. This movement is known as deinstitutionalization. Perhaps the true horror of deinstitutionalization is not what it sought to leave behind, but rather what it faces ahead. Deinstitutionalization and its legacy. This is Pablo de la Rosa, CMCI 1010. The idea of a psychiatric institution, or a place to treat the mentally ill, isn't exactly a new concept. Its roots can be traced back to medieval times, but it wasn't until the 19th century that these institutions became more widespread. Over the course of time, reliance on these centers increased. By the year 1958, approximately 550,000 people in the United States were residents in a mental asylum. This increasing reliance was rooted in an ideal, the dream that these institutions would somehow cure society of its ills, of the harmful eccentricities of certain individuals. This ideal, however, failed to materialize. Instead of being a safe haven, the conditions at many of these facilities were unspeakably cruel and brutal. People without a legitimate medical diagnosis were often held for months, even years, against their will. Many of these residents were poor and belonged to marginalized groups of society. It served as little more than a place for society to sweep the mentally ill and vulnerable out of sight. These misapplied services also posed a large burden to the state. In psychiatric care, there was a distinct lack of profitable opportunities, such as operations or procedures. Not only did the government have to pay for treatment, staff, and medicine, but the state also had to pay for the living expenses of all the residents. Economic unsustainability and inhumane conditions led to the death of the mental asylum. 3 waves of deinstitutionalization cut the number of residents in half by 1970. This trend continues to the present day, where the number of psychiatric beds is currently equivalent to what it was in 1850, 14 beds per 100,000 people. Many of these people transitioned to forms of outpatient care. In this new system of treatment, patients would live independently, with a focus on care based in the community. Not only was this a way to phase out unethical forms of treatment, but it was also projected to save the government large amounts of money, pleasing both progressive and conservative politicians at the time. Outpatient care was slated to improve both quality of care while reducing cost. Completely phasing out inpatient psychiatric care, however, has created a void of treatment for many individuals, especially those requiring the most acute care. Dr. Alan Kent, Director of Counseling and Psychiatric Services at CU Boulder, shares his experience with this deficit.
I used to work at DU. We would send someone to the hospital at noon because they were actively suicidal, and we thought they needed some time to get treatment and stabilization, and they would be back in the residence hall by 6 o'clock because the pressure to There were so many people waiting for beds, they would triage and send people out before they should.
Studies have shown contemporary inpatient psychiatric facilities are effective in stabilizing the most severe cases of mental illness, where extended stays provide both the environment and support needed for taking the first steps towards recovery. Sean Eisterer, a student at the Metropolitan State University in Denver, shares his experience of being in a psychiatric hospital.
Honestly, I had a really good time when I was with the other people. I met a ton of good souls and just genuine people while I was in there, and the instructors that talked to us really, really helped and really wanted to, help and fix things that were going on. They taught us some really cool games, too, like anti-suicide games, and they were very fun. Well, every night we had a movie night, and we would watch different clips from movies and figure out the person's feelings during that clip, and then figure out what the other person could have done to avoid making that other person feel the way they did.
Sean was fortunate enough to receive this type of treatment when he needed it most. He acknowledges the importance of this hospital visit as the first great leap forward in his path to recovery. The effectiveness of these facilities is indisputable. There are few easy solutions to the mess that is contemporary mental health care. Inpatient psychiatric care has evolved, following both medical and legal advances intended to both treat and protect the patient. The revivification of psychiatric institutions holds promise in treating this mental health crisis. Yet, the same problems that plagued the institutions of the past threaten to ensure institutions remain nothing more than the backdrop to a horror film, with a particularly chilling organ suite playing in the distance. This is Pablo de la Rosa, CMCI 1010.